Thank you, all the speakers and respected chairpersons, for such a wonderful session. Now we proceed to the presidential session. Hard work definitely deserves applaud and recognition. For this session, I would request the chairpersons to please come up on the stage. Dr. Neelam Shirsad, she is the Scientific Officer, Neuro-Oncology Basic Sciences, ACTRIC, TMC Mumbai. And Dr. Tejpal Gupta, Professor, Department of Radiation Oncology, Tata Memorial Center, Mumbai, and General Secretary of the Indian Society of Neuro-Oncology. So, Dr. Tejpal and Dr. Neelam. Now I request the chairpersons to take it forward from here.
Thank you. So it's my proud privilege to announce the two awardees for ISNOCON 2022. Most of you are aware that the Indian Society of Neuro-Oncology gives two awards, the President's Awards. One is for the best clinician researcher, which goes to a clinician working in the clinics who does some basic translational research. And the second ISNO President's Award is for outstanding work in neuro-oncology. So the ISNO Presidential Award for Best Clinician Researcher for year 2022 goes to Dr. Venkatesh Madhugiri, who is a neurosurgeon at NIMHANS. Dr. Venkatesh. So he will briefly be presenting the work for which he has received the award, and subsequently I'll announce later the President's Award for Outstanding Work in Neuro-Oncology. Venkatesh, the stage is yours.
Thank you very much, Dr. Tejpal and Dr. Neelam. And I think on behalf of all my collaborators, I want to thank everyone, especially the panel that decided that our work was worthy of this recognition. More importantly, I am thankful for the opportunity to talk about our work. So let me tell you a little bit about what we've been doing. I have two disclaimers. The first one is that what I'm going to be talking about today is very, very basic stuff. It's the beginning of a pipeline that I personally hope will end up in some form of therapy for this very bad disease with a dismal prognosis. But this is very preliminary work. Work is ongoing. So that's the first disclaimer. Second disclaimer is that as a neurosurgeon, what I will not be talking about today is I'm not going to be talking about the extent of resection and the impact that it has on gliomas and their prognosis. Nor am I going to be talking about intraoperative mapping and monitoring, which have become the standard of care in every operating room across the country. Nor am I going to talk about the technology that we as surgeons have come to depend on today and that also are incorporated into almost every operating room. Nor am I going to discuss with my fellow colleagues about the kind of strategies we use for difficult to excise glioma. So what is it that I'm going to be talking about? I'll be touching upon our work on inflammation in gliomas. And this is something thoda hatke. This is not mainstream, and I haven't heard any talks or any markers about that deal with inflammation today. They don't come under the mainstream of therapy. So let me jump into what we've been doing. So what is the story so far? I think most oncologists, it might be news to neurosurgeons, but most oncologists know that inflammation is associated with almost all solid organ tumors. And almost inevitably, the presence of inflammation connotes a very poor prognosis. And there are many markers that we use to measure this inflammation, right from the very sophisticated ones like T-cell migration, etc., down to simple blood counts and blood count indices like the neutrophil lymphocyte ratio. And I think almost everyone has heard of NLR today and the impact that it has on survival. However, for some cancers, it's even reached the stage of being protective and also being used for therapy. Prostate is a good example. Some anti-inflammatory agents, NSAIDs, are even said to have a protective role against development of these cancers. So what is the story when it comes to the brain? It's not a no-brainer because the data does not easily translate into the situation of brain cancers because it's been thought that the brain is an immune-privileged site. There hasn't been any data regarding the role of inflammation in gliomas prior to 2012. And 2012 is the date that I have put there because that's when we started our study. It's not some seminal date in neuro-oncology or anything. But the cause and effect relationship was not established. It was complex. We didn't know what the prognosis and the impact on prognosis was. And we didn't even know if the presence of inflammation in gliomas was clinically relevant at all or if it was just a curiosity. However, currently we've moved to a stage where we know that inflammation is associated with higher grade gliomas, and I'll tell you how we contributed a little bit to this data. So as always, these are the main players that we see in the story of inflammation. So back in 2012, I think my curiosity was piqued by a study that I read out of China. Unfortunately, I could not find that study. In fact, I had to Google translate it because it was a paper in Chinese. That piqued our curiosity, and we set up a prospective study in 2012 to look at inflammation in gliomas. And the access we had at that time was to very, very basic laboratory testing. And it took a long time for us to gather this prospective cohort because we had very rigid screening criteria, patients not on steroids, patients presenting primarily. We had a very strict age cutoff, and we finally managed to recruit 115 cases and 216 controls. And sad to say that this was not a homogeneous cohort at all. If anything, it was very heterogeneous. We included intraaxial, extraaxial, all grades, etc. But to our surprise, we found that when we put all of this together, we found alterations in literally every marker of systemic inflammation in all the patients in the cohort, in every type of brain tumor, intraaxial, extraaxial, all grades. And this was indeed a surprise to us. It was completely unexpected, and we did not expect to see these results. And then the question was, what do we do with this? So I'm going to pass down these results a little bit. I'm not sure if you can see the numbers, but this is a table where we took only the glioblastomas out of that cohort, and we had 36 GBMs there. And when we looked at the GBMs, we found that the differences between the controls and the tumor population was maximum for the GBM group when compared to the other brain tumors like vestibular schwannomas and meningiomas, etc. Okay, so the story just got more curious, and then we were left scratching our heads about what we needed to do next. And obviously the answer was to focus on the group that had a maximum inflammatory response, which is also my area of interest, and that's exactly what we did when we moved on to the next study. So we set up a study. The previous study was set up in JIPMER. This study, I had the fortune to have follow-up for the prospective cohort from JIPMER and a very, very robust cohort that I was very kindly given access to when I worked at Tata. And we had more controls that we recruited. And this was the largest study to date that I know of about inflammation in GBM, 743 individuals with 300 plus controls and 400 plus cases of only GBM. Remember that this was back in 2016, so we did not stratify it based on IDH. And what we did in this study was we correlated inflammation with patient-related factors, tumor-related factors, and finally with survival. A very simple study. So we analyzed all the routine markers that you've heard of, things like MLR, PLR, LMR. We also did systemic inflammation index and co-PNLR. So these are across all papers. So we studied literally all of these markers. And we managed to publish this. This was in 2021 because we accrued data right up until then. And I'll give you the TLDR version. Every parameter that we analyzed literally was different between controls and patients with GBM. So this we've established very clearly now. Compared to a normal healthy population, patients with GBM have a significant systemic inflammatory response. And also the circles that are in red are the parameters that are reduced. So all the lymphocyte and monocyte parameters are significantly reduced in patients with GBM, whereas the neutrophil-based indices are increased. And this is bad news because neutrophils are inflammation, whereas monocytes and lymphocytes are cell-based immunity, which are suppressed. And we have a lot of basic data that's coming out about that. So we try to determine some thresholds that might affect survival for all these parameters, and we were able to do so. And what we found was that once we defined these cut points and we defined an inflammatory profile, we found that this actually correlated not only with patient-related factors. This was unusual. For instance, patients with good performance status, patients who were not in altered sensorium, patients who did not have raised ICP, they had lower levels of inflammation. Similarly, patients who had a better molecular profile, who had retained ATRX, who did not have P53 overexpression, they had lower inflammation when compared to those who had poorer profiles. And the survival was dramatically different. It was more than double in patients who did not have a significant inflammation. And these are just the plots from there. So what we showed that conclusively patients with GBM had a significant inflammatory response. That inflammation correlated not only with survival, but also with clinical parameters and the tumor molecular profile. And this was very, very curious and very interesting because to our experience, this hadn't been shown before. And so then again, what do we do next? Because we've shown that there is inflammation, but we need to refine our findings. We need to refine it so that it becomes more robust and more generally applicable, and that's what we did. So we parsed the data further, and we took a cohort that was even more homogeneous. We took patients with GBM who had undergone standard therapy, completely resected, safe maximal. We didn't take anything less than near total, and who had then undergone chemoradiation and the prescribed number of cycles of temozolomide. And this time we looked at a hard parameter, overall survival. The first study that we did looked at PFS because it was prospective and we hadn't accrued the OS data. And this is what came out last year. And we defined a long-term survivor group and all the other groups, especially one which was short-term, less than 12 months. And again, we analyzed clinical and tumor-related factors. And what we found that, again, akin to the previous study, patient-related factors, younger age, longer duration of symptoms, the ones in blue are novel findings, better KPA score, and a better extent of resection. All of these, we know they were associated with long-term survival. Again, the molecular factors, so these factors which are already known acted as a kind of internal validation for this cohort. And that led us to what we found next, which was new. The markers of inflammation showed strong and consistent associations, and there was significant difference between the long-term and the short-term survivors. And so to summarize, many of the already known factors were reaffirmed by this study. But what we found new, once we knew that the cohort is valid and we have a good valid data, is that a longer duration of symptoms was associated with longer OS, and the markers of inflammation, all of them were significantly lower in the 3-year plus survival group. And several of the markers of inflammation were able to independently predict survival in a multivariate analysis, which included also all the known factors. So this is where we were when it came to inflammation. But we had been seeing one signal, which was a little tangential, throughout all these 3 studies that I spoke of. And this looked like the new kid on the block. And we finally decided last year that it was time to focus a little bit on this. And that doesn't actually tie up with inflammation. What we noticed that the eosinophil count had always been significantly higher in patients who had longer survival. And this was very curious because we didn't begin by looking for eosinophils at all. We now know that atopy and allergy are actually inversely associated with the risk of gliomagenesis. But the role of eosinophils and atopy in glioma biology is far from conclusive, and there are a lot of controversies. So as a clinician, I wanted to start from ground zero and see if we could prove this in a new cohort. So we took a subset of our previous cohort, and this hasn't been published, so this is unpublished data that is now under review that I'm sharing with you. And what we found that the eosinophil and basophil counts were deranged in patients with GBM, again when compared with healthy controls. And surprisingly, all the good pre-treatment clinical groups, the ones without raised ICP, the ones in normal sensorium, and the ones with good performance status. Sounds familiar? These are the same groups as the previous studies. All of them had a higher eosinophil count. And patients with good molecular profiles, again with ATRX and with lack of P53 overexpression, also had higher eosinophil counts. Now, please note that the same as in our previous cohort, I have to say this, but I can't explain it, there was no correlation with either the MGMT methylation status or with the IDH groups. And if you pin me down and say IDH is one of the most important prognostic factors, why aren't you seeing the difference between your IDH groups? I have no answer to that. But this is what we found. And we found that the absolute eosinophil count, when put together with the other known parameters, was able to independently predict survival. And this you can see, we found 2 cut points, and we found that any eosinophil count above 150, especially if it was more than 500, was associated with significantly longer survival. So what is the final summary so far? So peripheral blood counts and indices, even when something as simple as that is used to explore the role of inflammation, they strongly correlate with survival. And they will be incorporated into prognostic models because they are very simple to do, and it's very easy to obtain it at point of care. Longitudinal benefits, longitudinal measurements, I think like the kind that Dr. Tejpal is running in his study, the Indigo study, are going to have multiple potential benefits. They can become surrogate markers for tumor profiles if we detect markers that are sensitive enough. We're going to be able to monitor treatment response and identify recurrence versus treatment change. And all these roles are potentially possible when we put together bunches of markers. I just want to project this because this was across 3 institutes, and these were the people who were part of this journey right from the beginning. And I'm very thankful to all of them because they have contributed immensely to this study. But that's not the end. Like I said, this is the beginning of the pipeline, and I'm hoping that the end of this pipeline leads to some kind of therapy. So the study continues in NIMHANS, where I presently work, and these are the people who are working along with me. Dr. Vani Santosh, of course, provides umbrella mentorship to studies of this kind, and I'm very privileged to have her with us. Dr. Chandrajit, Nishant, who's here in the audience, and Dr. Abhineet, and 2 of my residents are all doing this work. So what is the work that we're doing now? We're trying to independently validate the inflammatory profile that we've described before and see if it does correlate with molecular profile and survival. We're also looking at the lower grade gliomas. We're looking at grades 2 and 3, and we're trying to see whether there's any difference in what we're seeing in these grades of gliomas, especially when it comes to survival. And I got fascinated with allergy and atopy, so I am looking at that now, and that's going to be another study under this umbrella. The last one is an investigator-initiated study that has been submitted or will be submitted for approval. The protocol is ready. We're looking at avoiding steroids in these patients because there have been signals popping up, throughout the course of the study on GBMs that patients who've taken steroids, who require steroids, for whom steroids can't be tapered, do much worse. So I'm not sure if the tumors are bad to begin with or if steroids have made matters worse, but we're going to pick tumors where we can avoid giving steroids in the perioperative period, and we're going to see if it makes any difference. And that might be the starting point to deciding how we can immunomodulate these patients. And the final hope is that, you might just give a patient 2 aspirins and you might prevent his brain tumor or maybe cure his brain tumor. We're very far away from there, but that's the final hope. And I'm really thankful to Dr. Anand, who's in the audience here, to Dr. Tejpal and Dr. Sridhar for the immense help with this project here, and for my student, who's now a resident, for his continued work on this project. Thank you very much.
I don't know if I'm allowed to ask a question award paper. Okay. So just a thought.
Yes, please.
Because steroids are known to increase the neutrophils and reduce the eosinophils.
Correct.
So maybe the patients who are doing worse, the tumor is increasing their cortisol levels. So maybe you should check the cortisol levels.
Yeah. So
those who are doing poorly or like their cortisol levels may be different. So it may not be inflammation. It may be just the steroids changed by the tumor speed at which the tumor is growing. More aggressive tumors are suppressing it more, and less aggressive are doing it. So you are picking biology by a simple test. Excellent study. But I think it may not be inflammation. It may be just the endocrine changes in the hypothalamus pituitary axis. You should look at the levels. And the inflammatory markers, you should look at like C-reactive protein and other things, interleukin-6, etc.
Yeah. So the present study that I said we're doing, we are looking at, so the inclusion criteria do include endocrine profiles, and we are going to include things like albumin and C-reactive protein also, which we did not have for the previous cohort because they were mixed retrospective, prospective. So the present studies do include all of that. Thank you.
Hi, Venkatesh. One question. Excellent presentation. Congratulations for your work. There's some recent data emerging about the tumor microenvironment being different in astrocytomas and oligos, especially the cytotoxic and helper cell T cell front. So it will be interesting if you can add in your subsequent prospective study about studying the T cell subset, the absolute, whatever you're saying, absolute lymphocyte count, to see what percentage of CD4 and CD8 cell, whether, and also tumor, primary CNS glial tumor subsets like, astrocytomas and oligos, maybe it might help you some aspect.
Yeah, that's very interesting. Thank you for the suggestion. So I'll talk to you about this and get back to Dr. Vani, because that might be something we would be able to do, and I think it will be very interesting. Thank you.
So very interesting study.
Thanks,
I would like to congratulate you.
Thank you very much.
Marvelous study. So tumor microenvironment, I think the inflammatory microenvironment does play a role in tumorogenesis and important role in deciding what would be the tumor immunity. So we have also done a study where we have used tumor tissue as such, and we have analyzed the inflammatory microenvironment in the tumor, and we have seen that it was mostly done in the midline tumors. So the tumor microenvironment in the pediatric age as well as in the adults is also very different. So
I see.
Yes. So the microenvironment in the adults is much more established. So the PD-L1 expression, PD-1 as compared to children. And as the tumor grade increases also, the inflammatory microenvironment is totally different. So,
yeah. So I think this is something worthwhile exploring, because we do have tumor samples for the entire cohort. So it's
like Dr. Sridhar said, you should now explore maybe on the same patients, like
right.
You have the patient, this thing, does it correlate with the systemic thing?
Right, absolutely.
That would be really interesting.
Yeah, thank you very much. Thanks,
One of the oral presentation is tomorrow on lymphopenia. We have shown.
I noticed that. Yes, sir.
There's a beautiful correlation of lymphopenia, and it's a 72 patient cohort.
Correct.
Prospectively collected. So it's, I think, coming together.
Yes, yes, sir. Right. Thank you, sir.
ISNO President's Award for Outstanding Work in Neuro-Oncology for the year 2022 goes to Dr. Sushmita Jha, who is a PhD scientist at IIT Jodhpur. May I request Dr. Sushmita to come and give her presentation. She'll be talking about inflammation in gliomas, not systemic inflammation, but in the tumor tissues.
Yeah, please. Can I have a Lisa pointer? Thank you so much for selecting me for this presentation, first of all, and thank you so much again for inviting me to talk about our research. Honestly, I feel like an outlier here, sitting in a room full of surgeons. So that's why I pointed out I'm a PhD here, so please don't come to me for medical advice. So today I'm going to be talking to you about our work over the past decade, looking at retro-engineering tumors. And it didn't really start out this way. So I thought we'll start at the very beginning. So I don't need to introduce glioblastomas to you anymore. All I would like to say is that we can all agree that they are extremely heterogeneous. What interests me most within this microenvironment is the presence of microglia, the innate immune cells. So in the healthy brain, you have 10 to 15% of glial cells constituting microglia. But within glioblastomas, we see 35 to 50% of these cells. So that was extremely intriguing to me. And we know now that in addition to the tumor cells, we have metabolism, immune cells within the glioblastoma and the tumor microenvironment playing a role in glioblastoma pathophysiology. But how does the body initiate inflammation? Extremely basic, right? So what I'm interested in are these pattern recognition receptors, specifically the ones called NLRs. Now these sense pathogen-associated molecular patterns, damage-associated molecular patterns, as well as irritants. And when they do, they form these multi-protein complexes called inflammasomes. Now these inflammasomes can actually cleave and activate caspases to release IL-1 beta, IL-18, and more than 70 other proteins that are involved in not just inflammation, but many other housekeeping functions. These are evolutionarily conserved and expressed by innate as well as adaptive immune cells. We also know that some of these form these multi-protein complexes while others don't. Importantly, when you have dysregulated NLR signaling, dysregulated NLRs lead to many diseases. And these range from Alzheimer's and MS to lupus, diabetes, and what was most interesting for me was cancers. But at that point of time, nobody had really studied cancers with NLRs. So we asked three questions. One, are NLRs differentially expressed in glioblastomas and low-grade gliomas versus non-cancerous brain tissue? Two, how does the tumor microenvironment alter innate immunity? And three, what are the key molecular signaling events? Now, to do this, we had to get clinical data. So that's where we had collaborators. So we set up a tripartite MOU between ACTREC, the Tata Memorial Center, AIIMS Jodhpur, and IIT Jodhpur for Indian patient data, glioma pathology. So we ended up getting patient samples, both fresh tumor samples as well as paraffin-embedded tissues, and we characterized them at IIT Jodhpur and carried out functional assays. Now, this is work done by my first PhD student, Nidhi, who's at Karolinska now as a postdoc. So what you can see on this extremely busy slide is that we looked at these seed NLR genes. Now, NLRs are a family of 24 proteins that are involved in innate as well as adaptive immunity. And what we found is that these proteins are critical for glioma pathology, specifically the ones that are listed over here as seed genes, P3, P6, P12, C3. Now, this was our first analysis, And what we could gather from here is that these genes seem to be important for glioma pathophysiology. But this data is not our data. It's not Indian data. It's from the Cancer Genome Atlas, and we use the C-Bioportal to analyze it. So we next looked at differential expression of NLRs in low-grade gliomas and glioblastomas. And what we saw is that, as you can see, there are some which are distinctly different between low-grade gliomas and glioblastomas. Specifically, NLRP12, caspase-1, and PICARD. So we carried out a patient survival curve for these, and again, P12 jumped out at us because we saw that in case of glioblastomas, a high expression of P12 leads to poor survival of the patients. Of course, we wanted to characterize it at the cellular level. So we looked at microglia as well as glioblastoma cells. And in case of microglia, if we inhibited NLRP12, we could see increase in proliferation. Now, to let you know, P12 normally is a brake for inflammation. So this tells us that having this brake switched off changes the innate immune microenvironment within the glioblastoma. Something which was very interesting is that in case of the glioma cell lines, if we block P12, you see the opposite. So it tells us that there might be a reciprocal regulation of innate immune signaling in these two different cell types. So us looking at the glioma microenvironment as one homogeneous environment might not be ideal. So that's exactly what we did. We looked at glioma tissues and we again found P12 to be higher within the glioma. This work was done by Shalini, who's now at the University of Chicago. We cannot underestimate the importance of the tumor microenvironment, and to study that at that point of time, we didn't have the sophisticated equipment, so we built our own. That's the advantage of being at an IIT. So we went over to the colleagues in mechanical engineering, and this is now under patent. So we built a hypoxia chamber, and we could show that in fact, hypoxia inhibits inflammation and NLRP12 expression and function, which means that within the tumor microenvironment, the expression of these innate immune genes, in fact, changes, which favors the tumor. While we were looking at the role of innate immune genes, we also started asking, can we actually alter the behavior of these cells, these microglia? That led us to a serendipitous discovery where we found that dopamine can induce microglial extracellular traps. Now, these extracellular traps are DNA-based nets, almost like what Spider-Man throws out when they're trying to trap their villain. In the same way, the cells actually throw out DNA to trap pathogens. So what we end up seeing here is that within the glioma core, you see these cells actually throwing out more of these extracellular traps. We know that in case of breast cancer, these traps are thrown out by neutrophils. So it's extremely interesting that microglia are throwing these out in case of gliomas. And this raises the important question, what are these traps doing there? And so our group is looking at this. So this is Ishan. He discovered the dopamine-mediated microglia extracellular traps. He's at Oxford now doing his postdoc. So until now, we've said that we study glioblastomas by cell culture, tumor studies on human tissue, as well as animal studies. But that's almost like saying, you know, the blind man and the elephant story, where one says it's the tail is an elephant and the other one says the trunk is an elephant. So in our hopes to understand gliomas, we can't think of them as 2D, right? So if you grow cells in cell culture, this is what they look like, nice flat structures, minding their boundaries. But when we grow primary cell tissue from glioblastoma tumors, they don't mind boundaries. They grow one on top of the other. This is what they look like. So then why study them in 2D? Why not in 3D? And that's exactly what we do now. So we know that the native tissue architecture, the tumor microenvironment, and the cellular crosstalk can be studied here. And so now Pritika, who is a PhD student currently working in our lab, has been able to create patient-derived glioblastoma spheroid, which we
have been generated in collaboration with neurosurgeons at AIIMS Jodhpur. So we get tissues from AIIMS and we are able to get three-dimensional structures. So we are also able to image these as the tumors grow. So as you can see here, this is day 0, where you have cells just in clumps come together, make spheroids, and by day 2, they're making actual structures which are heterogeneous in structure. What I would like to say is that they get very big. So in case of glioblastomas, growth is not an issue. We end up seeing very large spheroids. They are visible to the human eye. That is not the case for low-grade gliomas, of course, but we are working on these, and we've been able to get low-grade gliomas as well as glioblastoma patient-derived spheroids. We can characterize them, and we can see that within these patient-derived spheroids, we have microglia, we have astrocytes, we have glioma stem cells, and we can differentiate them so that they actually have endothelial cells too. Now, this has multiple applications, not just in case of precision medicine, but also in drug discovery, understanding of development, and in case of toxicology studies. So what we are doing now is in collaboration with colleagues in the computer science department who are working on AI-based continuous learning models, colleagues in our department who are working on computational biology, as well as colleagues across different hospitals, including Tata Memorial, AIIMS Jodhpur. We are getting patient data and developing a multimodal data repository and hoping that one day we can build an AI-driven framework for radiogenomics. So in conclusion, we've been able to discover the novel role of innate immunity in glioblastomas. This is our first report of NLRP12 as a prognostic marker in glioblastomas. We've been able to show a link between the tumor microenvironment and innate immunity in case of GBMs, and we have now developed patient-derived glioblastoma spheroids. This work could not have been done without the work of all of these students who have come to our lab over the years. So some of them are now all over the world, and some of them are here in my next acknowledgement slide. And of course, this could not be possible without collaborators such as Dr. Gupta, Dr. Rukmini Govekar, Dr. Sridhar, who have made sure that we get the perspective from the clinician side as well as the pathologist side. And of course, Dr. Deepak Jha at AIIMS Jodhpur, who's been kind enough to give us surgical samples so that we can build these spheroids. Dr. Sumit Kalra and Dr. Deepak Mishra, who are computer scientists who help us build these AI models. Dr. Santanu Chaudhary, who's a collaborator as well as a director at IIT Jodhpur, with whom we've been able to get funding from the Ministry of Electronics and Information Technology for tumor spheroids for precision medicine. Of course, the funding agencies, and if you'd like to visit our lab, you can just scan the QR code right there. Thank you so much for your attention.
Questions? I think it was a stunning talk. Any questions?
Yeah.
Yeah, excellent work, and basically now looking into this immune aspect, which has been ignored, I think, in terms of brain tumors,
Yes.
thinking that brain tumors, there is no immune
Immune
privilege.
privilege.
So, but experience, I think, and I think clinicians should see whether before actually there is tumor occurs, and you see that there is almost, I think, always an immune suppression in an individual.
Right.
I don't know whether you see that clinically. That there is immune suppression. Does this patient tend to fall sick with some kind of infection or something before that? And so immune, I think inflammation, there is another aspect is actually immune suppression. It doesn't have to be only through PD-1 and PD-L1. So I think what Dr. Sridhar said in terms of cytokines. Absolutely. And what kind of T cell so there. Inflammasome right now is a hot topic, and I know that. Yeah. But I think one needs to look into all aspects in terms of what the immune, in terms of immunity, what the tumor microenvironment is looking. As you said, it's no point looking at elephant, like blindly looking at an elephant. One needs to now really study all the tumor microenvironment in terms of cytokines, T cell supplies. But it was a very good beginning, and you have also made these 3D cultures. So
Yes,
that's
ma'am.
really a good thing, very good study.
Thank you so much. Yeah, so we've been able to actually culture and characterize the different immune subtypes also. So I didn't show that data today, but that would be very interesting to discuss. Yeah, thank you so much.
Thank you, Dr. Sushmita.
Now it gives me great pleasure to invite Dr. Purna Kurkure, President of ISNO. It's briefly, I think everybody knows, she doesn't need introduction. She is very much associated with ISNO for a long time. She was head of the department and was someone who started pediatric oncology is what at Tata Hospital. And rare pediatric oncologists are not too many who are associated with neuro-oncology and take so much interest in neuro-oncology per se. And she has been president and secretary of various national and international societies. And currently, she is now working as senior advisor at Oncology Collegium, Narayana Health Head. She's a head of pediatric hemato-oncology at SRCC Children's Hospital, which is managed by Narayana Health. And she's trustee in charge of survivorship rehabilitation division of Indian Cancer Society. She's joint secretary of Indian Academy of Pediatrics. And so I think now I invite her to give her talk, her presidential oration of this.
Good afternoon, and thank you for having faith in me as and giving me this honor of being president, and today giving presidential presentation on behalf of this Indian Society of Neuro-Oncology. Due to the perseverance and the hard work of many dedicated people in the audience, Indian Society of Neuro-Oncology, which is now already in the second decade of its existence, has paved its path. It has a huge membership, and we have to still grow further. There are many illustrious presidents before me who have talked about the basic science and new technologies and many other issues which are related to neuro-oncology. As a pediatric oncologist hardcore, we face these issues of what next after you have cured the cancer. Because children have the whole life ahead of them. Each child that you cure adds to the population, a child at risk, but has a whole life ahead of it. So how do we tackle this issue? So I thought that perhaps after listening to all the very hardcore sciences all through the morning sessions and looking at how we can improve the survival, let us now look at this different aspects of neuro-oncology, which really pertains very much to a pediatric oncologist. That is how I have titled my today's presentation as Neuro-Rehabilitation in Pediatric Neuro-Oncology, and whatever efforts we have made in this direction by getting the stakeholders together on one platform and facilitating the journey of these children who are suffering from brain tumors. As we all know, we talk about this graph all the time as a pediatric oncologist as to how we have improved the survival in most of the pediatric cancers. Topping the list is acute lymphoblastic leukemia and so many others like Hodgkin's, which are in excess of 90%, and there is an overall survival of around 83.9% as depicted by SEER, Surveillance Epidemiology and End Result Program of USA. So there is a large amount of survivorship, and we have the children who are surviving these cancers. And as you can see, those pediatric oncologists, and it is not very talked about things in our community, brain and CNS, the central nervous system tumors, they have a good survival to the tune of 75%, and they constitute around 25% of the solid tumors, 20 to 25% of the solid tumor. So it is a very significant number, and we must pay attention to this aspect. In past, not long ago, in 73, nurse practitioner said that if someone lived long enough to develop long-term complication, we would jump for joy and treat the complication. Because those were the days when we were struggling and grappling with finding a better survival, and survival at any cost. But now with the refinement of many of these steps that we have taken by doing the correct risk stratification, treating these children appropriately for their risk, we are getting more and more survivors, but we can't afford to have the complication. Because there is a complete change in the medical outlook as an ensuing coping task. In past, coping with imminent was the concern, because diagnosis of cancer was ultimately, it was amounting to death. In pediatrics, it's a very rapid course, and many of the conditions, if untreated or not properly treated, would result into mortality. But at present, we know how to treat, and diagnosis of cancer is not equivalent of death, but either it is a cure or death due to the progression, and each disease has its own natural history. So there is a long disease course, and we have to cope with this uncertainties. We, as well as the parents and the family, they have to cope with these uncertainties of life. And how do we do this as we go by? As the cure rate improves, the quality of survival becomes more significant. Complete cure and not just the freedom from cancer is the goal, and thus we have to balance the risk of treatment modality in hampering the quality of life versus the contribution of each component of treatment that we use to achieve this cure. So this balancing act is a very, very important for pediatric oncologists, and I think this philosophy is coming up even in adults as to what is the quality of life at the end of the treatment. The cancer control continuum is thus not only prevention, early detection, diagnosis and treatment, but with the more and more people surviving, survivorship has become very important facets of this journey. End of life care and a palliative care was introduced much earlier, because those days there were more of advanced diseases which required this care. So palliative care as a specialty has been recognized much earlier than the survivorship, because survivorship is a more abstract phenomena as to how this survivors they fit into the society. But long-term follow-up, late effects management, rehabilitation, coping and health promotion, these are very important components of survivorship, particularly for children. So in 1986, not very long ago, it was started, the Office of Survivorship was started in National Cancer Institute, and it was defined as an individual is considered a cancer survivor from the time of cancer diagnosis through the balance of his or her life. But the disease-free survival for children for at least 5 years from diagnosis is considered as a long-term survival. However, every person who gets diagnosed goes through this season of survival. During the acute stage, it is the diagnosis and treatment part. In extended stage, during remission and maintenance, And the permanent stage is a long-term survival when you cross the 5 years landmark, which may amount to curing many of the childhood cancers. And final stage, when you fail to achieve this cure, is the end of life. So this distinct 4 survival seasons have been described in a beautiful article by a physician who himself had a colon cancer, Fitzgerald Miller, in the essay in New England Journal of Medicine. So what is the magnitude of problem? It has been said that in USA by the year 2020, which has gone by, number will exceed 500,000, and 1 of 530 young adults between 20 to 39 years in the society will be childhood cancer survivor. In India, we don't have such definite estimates, but we estimate or we guesstimate that around 60,000 new cases of childhood cancers are existing in the country. And with the conservative estimates, because of the different level of care, of 20% survival also, we are adding around 10 to 12,000 survivors to the population every year. And the determinants of these late effects are host factors, tumor factors, and treatment factors. And the interaction of this, they really decide the late effects. It is not a direct cause-effect relationship, but the interaction of these 3 important factors which decide the late effects and the quality of life. The consequence of cancer survival comes as many forms, like physical, anatomic, or functional changes, organ toxicity or morbidities that lead to premature onset of chronic illnesses, that is senescence, psychological disturbances, socioeconomic burdens, and most importantly for children who have a long lifespan ahead of them, increased risk of second malignancy. The consequence of survival in neuro-oncology, as we all know, is a very important thing for children in particular, because neurocognitive functions and the aspirations and achievements are all based on this very fine faculties that you gain, the neurocognitive, hearing, all the sensory losses, hearing, endocrine, vision, cerebrovascular accidents, vertebral anomalies, and second malignancies. And tools to detect these are patient-related outcomes. Now, patient-related outcome has become a very important aspect in most of the clinical trials. The clinical trials are more and more suggesting that as you look at the progression-free survival and overall survival, also one has to look at the patient-related outcomes and quality of life. The tools can also be applied to see the cognitive testing, functional testing, and imaging. So consequences of survivals in neuro-oncology are many and quite complex, and one needs to look at it very carefully. There is a huge cohort of childhood cancer survivors which are being followed up very prospectively in longitudinal assessment. That is called Childhood Cancer Survivor Study Group, CCSS. And they have looked at the late onset neurological conditions in survivors of childhood central nervous system tumors. And the importance of this study in this large cohort, which looked at more than 14,000 survivors, is that it is an ongoing process. And the risk of developing the late problems, neurological sequelae, they do not go away by the years that they are under follow-up on a longitudinal scale. So there is a late onset neurosensory and neurological sequelae which remain as a constant problem through the years of primary cancer diagnosis. So the y-axis is years since primary cancer diagnosis, and as you can see here, all the problems like seizures, tinnitus, cataracts, coordination problem, hearing loss, glaucoma, motor problems, retinal conditions, they are all there and they keep on increasing as the years go by. They don't decrease or disappear. So this is a constant point, and this has to be kept in mind as we look at these children who are surviving. In UK, they looked at the pediatric neuro-oncological rehabilitation in the UK with all CCLG groups and their perspective as to care and provider. So what is new? Like they looked at their own system of NHS and that survivors of childhood central nervous system tumors are at significant risk of adverse late effects. Rehabilitation is therefore a key part of the journey to recovery. So in NICE 2005 guidelines, they came up with the suggestion that they should have an access to such neuro rehabilitation program. The provision of rehabilitation services after childhood brain tumor has not been specified by healthcare purchasers, despite a recent parliamentary call for urgent action in 2018. The services currently provided and their perceived ability to meet the needs of affected families have not been assessed. So they conducted 2 surveys to the provider and to the stakeholders, that is the patient and the family. And this study highlights an urgent need to establish equal access across the UK to a comprehensive neuro-oncology rehabilitation services for children, young people and their families. The first insight into the core needs of young people and their families from neuro-oncology rehabilitation services and barriers to accessing services and gaps in services. So though it was advocated in 2005, in 2018, post-2018, after the parliamentary call, when this survey was done, still it is not implemented. So giving the guideline or telling it and implementing, there is a big gap. There is some problem. The other very important aspect is late endocrine effects. In the same childhood cancer survivor study group, 14,219 5-year survivors with median 32 years at last follow-up, the cumulative incidence and prevalence increased across the lifespan and risks significantly higher with high-risk therapies for primary tumor, hypothyroidism, thyroid nodules, thyroid cancer, growth hormone deficiency, obesity, and diabetes mellitus. Higher prevalence of premature ovarian insufficiency and testosterone. Survivors, there is an increased risk for all thyroid disorders and diabetes mellitus, regardless of treatment exposures compared with the siblings. So this is one of the very important aspects for a growing child. And the endocrine sequelae in survivors of brain tumor depends on sex, age, and pubertal stage, tumor location, and treatment exposure. Distinct profile of endocrinopathies based on above needs a targeted endocrine monitoring. Endocrine treatment should be supervised by an experienced endocrinologist. Fertility preservation, treatment of infertility and sexual dysfunction are often overlooked in those who become young adults. And adult survivors of childhood and adolescent cancer require multidisciplinary long-term follow-up. And these endocrine late effects, why there is a disruption? There is something pops up. Can you please? No, something. And these late effects may start early because in this endocrine sequelae, you need not wait for many years. And childhood growth and development phase is a very important phase when you have to be aware of it and intervene very early. 22% of childhood brain tumor survivors, there is at least one endocrine disorder within the first 5 years after diagnosis. So they need not be long-term survivors. They can develop it very soon. Growth hormone deficiency, central pubertal 20.2%, thyroid TSH deficiency and thyroid and hypothyroidism. They are all seen quite early. So this risk increases embryonal brain tumors, median follow-up over 5.6 years. This is our, and 72% had at least one endocrine disorder, 29% had more than 2 hormonal deficiency. So median time to develop hypothyroidism was 2.8 years and range being 5 to 8.5 years. So from cranial spinal irradiation. So you can see that these endocrine problems need not be very late problems. It can be soon after treatment, and one has to be sensitive about it. In growth hormone replacement, there are many questions which are still not very clearly answered as to when would you start the growth hormone, because there is a fear of reactivation of the tumor. Basically, it is decided by age and pubertal status of child, remission status, ideal scenario versus practical considerations, because we all know that growth hormone itself is a very costly treatment. When would you stop growth hormone? Is there a role for growth hormone supplementation in adults? And what are the safety concerns with respect to growth hormone? Access and affordability continues to be a concern. At TMH, with the efforts of Dr. Rakesh, we had started this growth hormone through a donation from an Austrian charity group, and then it has been taken over by other charity concerns. But I'll just touch upon this very shortly. So you require a long-term follow-up program for these survivors, and that should include at least a single physician who is interested in late effects, a nurse or nurse practitioner, a dedicated time and place where we can switch off from the too much active treatment and science and dedicate this time to the survivors, at least 2 follow-up clinics a month, comprehensive care and screening for late effects based on the survivor's treatment, referral to appropriate specialist and wellness education. All this form the component. So we started this after completion of therapy or ACT clinic at Tata Memorial Hospital based on the learnings from the St. Jude, who started this in earlier, but we started it in 1991 with a single objective or objective of monitoring growth, development, sexual maturation of survivors, monitor late effects of therapy to address psychosocial problems of the survivors, rehabilitation for useful productive adulthood, and to provide feedback to the oncologist, to the team for future protocol modification to obviate or minimize this late effect. And this again is a multidisciplinary team where a pediatric oncologist works with a clinical psychologist, medical social worker, and with array of healthcare professionals to take care of this surveillance plus rehabilitation. And after evaluation of survivors in ACT clinic based on the risk factors, how frequently they should be evaluated, they undergo this whole surveillance history-wise, examination-wise, and investigations. Psychosocial evaluation forms a very important aspect. Scholastic performance, psychological, psychosocial problem, employment of merit status, and rehabilitation status. Then they are given the medical summary, which can be considered as a passport plan for health and a recommended plan for follow-up. It provides internal and external physicians as well as the patient with the, like you want to become a patient-centric now. You want to give them the responsibility of their life and health. So cancer treatment, the patient has received, late effects of treatment manifested, and preventive care recommendations are all part of this document which is handed over. Even SNO, Society of Neuro-Oncology, has come up with this document of Neuro-Oncology Patient Survivorship Plan. And that headings or under the whatever is applicable for a given patient should be noted down, like diagnosis and treatment summary for all, final pathology report. Now today will come with the molecular events details. Tumor-directed therapy with surgery, chemotherapy, radiation, and other targeted therapies. What are the symptoms and symptom management medications that patient is on? Whether fertility preservation was advised and done. Healthcare providers who are involved in their care, their contact numbers and their details. Any supportive care referrals during treatment, if it was done. Genetics, particularly for predisposition syndrome, whether it was done, not done, then it will amount to having a surveillance for those syndromes like leishmaniasis has a certain set protocol of how to follow up these children. And then we write the follow-up plan in terms of how frequently neuroimaging is required, any blood work is required, and what are the long-term complications that you are anticipating and going to follow up for a given survivor. So this, in short, is a management plan which is being handed over to a survivor who has to be in charge of his own life and health. What does young neuro-oncology patient and survivor community want? They want a desire. They have a desire to know what to expect. Better mentorship, home care, and personal support. The importance of understanding and accessing long-term care, and increase uniformity in the standard of care that they receive. In addition to ACT clinic, which is a medical effort of looking after the late effects, we started this childhood cancer survivors support group called OGAM in 2009 by the survivors themselves who were attending this ACT clinic at Tata. And this complete model of care was established where medical late effects plus many other components like wellness education, medical social worker, nurse practitioner, referral to specialist, comprehensive care and screening, clinical psychologist, advocacy, and support group like UGAM, they become a complete comprehensive care to the survivor. And we came up with this model or components of survivorship program, which has a medical and societal aspects, where the late effects are followed, taken care of in the ACT clinic, and survivorship or societal aspects are being taken up by the support group or any NGO. UGAM functions under Indian Cancer Society. And the mission of the survivorship program is to address the outcome of cancer and its therapy and improve cancer survivors' health and quality of life through integrated programs in patient care, research, prevention, and education. We felt that these needs are not met with. Survivorship issues in India are not channelized through structured survivorship program. There is no national or state level policy that addresses employment and health insurance problems faced by cancer survivors, no database to measure the outcome of cancer, and therefore we need to make a very structured program. And through Indian Cancer Society, we started this project Picasso, that is Partnership in Cancer Survivorship Optimization, with an objective to decrease the loss to follow-up, bring the survivors into one area, increase the awareness of late effects and monitoring for early detection to them, encourage disease-specific support groups. Now, we have not reached yet that stage to improve the quality of life and to integrate survivors into mainstream of society. And the methodology that we have adopted is we have partnered with hospital to facilitate our experience of ACT clinic at Tata to other centers with a high volume pediatric cancer care, to develop psychosocial and rehabilitation module and to partner with organizations to help survivors to integrate into mainstream. We have partner hospitals in this Picasso projects across the country. In Mumbai, we have tied up with all the academic centers like KUM, Wadia, Sion Hospital, and also at SRCC Children's Hospital. In Delhi, we have partners in AIMS and Rajiv Gandhi. At Chennai, we have with the Adyar Cancer Hospital. In Bangalore, Mazinda Shaw, Narayana Health Service and Shankara Hospital. And at Varanasi, wherever Tata Hospital has their units, we are trying to reach out to them at Homi Baba Cancer Hospital, Varanasi, and in schemes at Srinagar. So there is a footprint across the country in setting up this module. And the young neuro-oncology patients and survivor community want that all children with CNS malignancies should have an access to neuro-rehabilitation service during treatment and for years following treatment. Cancer networks should liaise with other national health services, trust, and many other local NGOs and health boards and agencies to establish such rehabilitation strategies for psychosocial support and communication. All children with cancer and their families are offered psychosocial, psychological support and clear routes of referral in primary treatment cancer centers and other treatment settings, including during long-term follow-up. An appropriate key worker is assigned to all patients on long-term follow-up. So with this in mind, now that we have many ACT clinics across the country and we are trying to develop or pilot this neuro-rehabilitation module in Mumbai in partnership with Tata Hospital. I am now speaking from the other side of the desk, that is Indian Cancer Society. So we have patients and families who are in the Neuro-Oncology DMG of Tata Hospital. And we have Indian Cancer Society with a rehabilitation center who can assess, check the criteria for the referral, and then provide the reference to the third party, that is SRCC as a child development center. And that has I'll just tell you about so Indian Cancer Society is interposing and acting as a bridge between the DMG, Neuro-Oncology DMG on one side, and more advanced rehabilitation services which are lying in the Child Development Center at SRCC. As you can see here, at Indian Cancer Society, in addition to rehabilitation, we have many other activities like education, helping them with the jobs and better quality of living. By addressing the late effects, we are trying to improve the quality of life for these survivors. We have education and vocational skill funds, and we have almost to the tune of 1 CR. We have given the fellowship, educational fellowships to all the survivors, childhood cancer survivors coming from all the ACT clinics. So we have kept that as a constant platform for referral so that we can track and see whether they have achieved the milestones for which they were aimed at. So that is how the ACT clinics acts as an anchor to refer the patients for rehabilitative service. Late effect funding also we are doing in terms of growth hormone support, hearing aid, which has been just initiated, prosthesis, and many other investigations for late effects arising out of the assessment at ACT clinic, like endocrine workup is very costly affair. So that which is followed by the growth hormone replacement. We have a new rehabilitation center which was inaugurated in January 2021 at Indian Cancer Society, taking care of many of the occupational needs, occupational therapy needs, plus physical rehabilitation. And now we are tying up with the Center for Child Development, which is run by Society for Rehabilitation of Crippled Children. And it was started way back in 1948 at the time of polio epidemic. And the same trust has converted that orthopedic hospital into now SRCC Children's Hospital, where I am placed. So using this opportunity, I thought that perhaps we can tie up and give this benefit of services to these needy survivors. And there are scope of services which are available at the CDC, like physiotherapy, occupational therapy, prosthetic and orthotics, vision therapy, dance and movement therapy, nutrition, cognitive behavioral therapy, clinical psychology, education and remedial therapy, speech therapy and aquatherapy. So all sorts of rehabilitative services are available, and the advantage is that they are exclusive pediatric rehabilitation. They know how to handle the children. All therapies are under one roof. There is individualized rehabilitation therapy plan, certified and qualified and experienced clinical staff, and state-of-the-art facilities. So I will just give you one example of vision therapy. Generally, low vision or a partially sighted is not a blind, and a functional visual assessment is important. Visual rehabilitation gives a very gratifying results and lifelong impact on the child's future. So it's a new vision for independence, and there are many optical devices, magnification, illumination. My ophthalmology, pediatric ophthalmology and ocular ophthalmology colleagues, Dr. Himika, she looks after this department in the CDC at SRCC CDC, and home-based kit for smaller kids can be developed at a very low cost. And the one example is a 10-year-old boy who was a student of 6th standard and had a brain tumor involving the visual pathway, advised to shift to blind school by a very cursory ophthalmological evaluation. But when detailed evaluation was done and he was offered optical device, spacious spectacle with magnifier, and can read his textbook and can continue in the same school. And that happiness which you can see on his face with this new simple device which allows him to go back to his school is very, very great. So this module is now in place, between Neuro and I thank Dr. Tejpal and his team and Dr. Archer who is here. They have taken a lead and they have realized the need for such rehabilitation efforts. Indian Cancer Society, which is juxtaposed between them and another specialist service, that is SRCC. So I will end by saying that the good physician treats the disease, but the great physician treats the patient who has the disease. And these are the words of Sir William Osler. And we should become from the good physician to the great physician. Thank you.
Thank you, Dr. Kurkure. You have initiated not just a pediatric oncology, but now the survivorship program, which is probably a neglected subject. Nobody would have taken care so much. And you have not just initiated, grown it in such a scale. Multiple places, multiple cities in the country. Congratulations, and it's really a great result.
May I now request Dr. Neelam to felicitate Dr. Kurkure by giving her the plaque for the presidential oration. Will we have a round of applause? Madam to felicitate the two winners of the ISNO President's Award for the year 2022. Dr. Venkatesh, can you please come on stage? There is a check of 10,000 rupees also. Dr. Sushmita, can you please come on stage?